Hello everybody and welcome back to my YouTube channel Cardiology for You. I'm Associate Professor Jana Simova and in today's video I'm going to speak about aortic stiffness or arterial stiffness. And the purpose of this talk, my dear friends, is of course to explain what is arterial stiffness, but also to show you that it is a very easily measurable parameter and that it could be useful in our daily clinical practice. So, if you are ready, let's get into this video. So, dear friends, there are many factors that could contribute to the damage of arterial vessel wall and to development of arterial stiffness. And these are aging, hypertension, some metabolic diseases like diabetes, obesity and other connective tissue diseases, poor vascular health in general, sleep disturbances, etc., etc. And all these factors could lead to the damage of the vessel of the wall, which includes a fragmentation of the elastin, fibrosis, senescence of the smooth muscle cells, and calcification. And all of these are the basis of arterial stiffness. And on the other hand, arterial stiffness leads to hypertension, and especially isolated systolic hypertension. It could also lead to cognitive impairment and to stroke, to heart failure, to chronic kidney disease and to aortic aneurysm. I would also very much like to impress and to show you that there is an interaction, a bidirectional connection between arterial stiffness and high blood pressure. So, we have seen that many factors such as aging, diabetes, etc. lead to a damage in the vessel wall to endothelial dysfunction, and this induces arterial stiffness, which on its turn leads to increase in the blood pressure. On the other hand, hypertension, high blood pressure could also damage the vessel wall and could further worsen the stiffness of the arteries. So really we have an interaction between arterial stiffness and arterial hypertension. I would like now to cover just in brief the guidelines that have mentioned or made some comments on the measurement of arterial stiffness. I would like to start with the newest one, the one about the ESC/ESH guideline for the management of hypertension from 2018. In this guideline, as you may already know, it is stressed that all patients with hypertension should have an evaluation of hypertension-mediated organ damage. And for the more detailed screening for the hypertension-mediated organ damage, the measurement of arterial stiffness is also included as represented by the measurement of the pulse wave velocity. As a level of recommendation, it gets to be a level. Another guideline, which is from 2017, this is the guideline for non-invasive cardiovascular imaging for the evaluation of subclinical target organ damage in the hypertensive patient, and it is developed by the EACVI and the European Society of Hypertension. As is said also in the title, you could guess that the main focus would be on subclinical and target organ damage, because the authors stress that this asymptomatic organ damage is an independent cardiovascular risk factor and should be searched for and identified in every patient with hypertension in order to reclassify the patient's risk. Also, here in this document, it is stressed that non-invasive imaging tests are very well suited for the purpose of evaluating subclinical organ damage. And as we talk about the subclinical organ damage on the level of the arteries, we see here that the things that are recommended are the carotid femoral pulse wave velocity as a measurement of arterial stiffness with a cutoff value of over 10 meters per second. Also, intima-medial thickness and ankle brachial index. In this guideline, there is a very useful scheme. It is a little bit outside the scope of just arterial stiffness, but I would like to get into it a little bit because I really think that it would be very useful for you. When starting to evaluate a patient with hypertension for subclinical organ damage, the basic tests that should be done to all of the patients include, of course, history, 12-lead ECG, urine dipstick, serum creatinine with eGFR, and transthoracic echo. And then come the advanced assessment of target organ damage, which depends on the clinical situation. If we have patients with suspected coronary artery disease, then we should try to prove if there is a myocardial ischemia, which is done at first maybe with a stress ECG test, but if this test is inconclusive and or it could not be performed, then we go to some kind of imaging stress testing. Then if we have the patient with an intermediate score risk, here it is very useful to search for some markers of subclinical vessel damage, arterial damage, which are the pulse wave velocity, calcium score, or the ultrasound scanning of the carotid arteries. Also, there are other situations, patients with difficult to control hypertension, they should be evaluated by fundoscopy. Those with long-standing hypertension should be evaluated for the abdominal water because they have a higher risk for abdominal aortic aneurysms, and those patients with cognitive impairments should be evaluated by a neurologist, maybe with a brain MRI. And the last of the guidelines I would like just briefly to touch is the recommendations for the use of echocardiography in adult patients with hypertension. And it is from the echo societies, the European one, EACVI, and the American one, the American Society of Echo. Here you could see that the authors distinguish 5 different components of arterial afterwall. I would not go into detail about them. I would just like to focus your attention to what the authors have mentioned just after the 5 types, and it is that the measurement of carotid femoral pulse wave velocity is currently considered as the reference standard for the measurement of arterial stiffness. So, just in brief, because I would go to the part of measurement a little bit later, but just in brief, to measure velocity, we have to have 2 things: the distance between the carotid and the femoral arteries and the time, because a velocity is measured when the distance is divided by the time. So the distance between the 2 points where we measure and the time that is needed for the pulse wave to reach from the first side that we measure to the second side that we measure. I must show you that the reference values for the pulse wave velocity are different in different age categories, and also it is very important to know that the relationship between pulse wave velocity and cardiovascular disease is linear. But when pulse wave velocity reaches a value over 10 meters per second, then this implies a significant impairment of aortic function. And in this guideline, the final recommendations are that every echo examination should report about the blood pressure at the time of the measurement. Also, aortic dimensions should be reported in all of the studies, and the measurement of pulse wave velocity should be considered as a marker of the vascular health and the risk of these patients. So this was about the guidelines. So we have seen up till now that there is a close interconnection between arterial stiffness and pulse wave velocity. So the stiffer the artery, the higher is the velocity in this artery. And there is a very important principle that stays behind the fact that our arteries should be elastic, not too stiff, not like some rigid tubes. Because if you see this simple figure, when the ventricle contracts, the valves open and then an amount of blood is ejected from the left ventricle to the aorta and the large arteries. They are expanded, and this time they are able to store some of the kinetic energy of the blood into potential energy in the vessel wall. And therefore, when the systole ends and ventricular diastole begins and the valves close, the semi-lunar valves close, then we don't have such steep drop in the blood pressure as we have in the left ventricle to nearly 0 or to 5 or 6, because we have these elastic properties of the vessels, and their walls are elastic, not like rigid tubes that just are a passage for the blood. And so in this period, this potential energy stored in the walls of the vessel again transforms into a kinetic energy. There is an elastic recoil, and the blood pressure that we observe in the arteries is around 80 and not around 5-4 as it is in the left ventricle. So you see how large amplitude has the blood pressure in the left ventricle in normal subjects, from almost 0, 5, 6 to 120 in normal persons. If we have these large amplitudes in the vessel walls, they would get damaged too quickly. They would get broken, they would get stiff, they would not serve us well. And namely because of their elastic properties and the fact that they are not stiff by default, we have this minimization of the amplitude in the arteries, and in this way they are able to preserve the properties of the walls of the vessel for a long period of time. And you see that here we have a systolic pressure, a diastolic pressure and a pulse pressure, which is defined as the difference between the systolic and the diastolic pressure. In normal conditions, when we have normal compliance and normal stroke volume, then we have normal systolic and diastolic blood pressure and normal pulse pressure. When the arteries get stiffer, less elastic and with lower compliance, then we have, with the same normal stroke volume, an increase in the systolic blood pressure, decrease in the diastolic blood pressure and increase in the pulse pressure. So the pulse wave that we usually observe in the arteries is in fact a sum of the ejection wave and the reflected wave that comes from the periphery, and they are summed and look this way. In the young people they look like that, in the elderly persons they look like that. And if we consider this pulse wave form in more details, we could see how important it is to have elastic and not stiff arteries. The normal configuration of the pulse wave should follow this green line. However, when the arteries get stiffer, then the ejection wave, the one that gets out from the heart to the periphery, it travels faster to the periphery. It gets early to the point of reflection. It gets reflected earlier, comes back earlier, and builds up earlier on the forward propagating ejection wave. And this earlier building up on the forward propagating ejecting wave leads to some serious consequences. For example, this increase in the central pulse pressure increases the risk for stroke and chronic kidney disease. It also increases the afterwall of the left ventricle and increases therefore LV mass and accelerates the progression to heart failure. There is also another very important thing. When this reflected wave comes earlier and builds up on the former, earlier part of the pulse wave, then it does not build up on the second part, and therefore it does not contribute to a normal diastolic pressure, and therefore the diastolic pressure gets lower, and this decrease in the diastolic pressure leads to a decreased coronary artery perfusion pressure in diastole and to an increased risk for ischemia in the myocardium. Now we come to the measurement of pulse wave velocity. I told you it is easy, and I really believe in this. It could be measured with every kind of echo probe. It could be a vascular, it could be standard transthoracic echo, it could be even abdominal. What you have to do in order to calculate the velocity is to have the distance and to divide it by the time that is needed for the pulse wave to reach from the one side to the other side of the region that you want to measure. So if we are talking about the carotid femoral pulse wave velocity, we should measure the distance between the carotid and the femoral artery and divide this distance by the time that is needed for the pulse wave to reach from the carotid artery to the femoral artery. And this time you could very easily get following these instructions. Get the probe with an ECG on the side from which you have started your measurement on the carotid artery. Then measure the time between the onset of the QRS complex and the onset of the pulse wave. You could get this pulse wave with every kind of Doppler probe, every kind. So you measure this time. Then you perform the same procedure on the femoral artery at the point where is the last point of your measurement. So there you measure again the time between the onset of the QRS complex and the onset of the pulse wave velocity, which again could be obtained with every kind of Doppler probe. And when you subtract these two times from the QRS to the Doppler and from QRS to the Doppler here, you get this time. This is the time that is needed for the pulse wave to reach from the carotid to the femoral artery. So really very easy. Just try it, and if you have some questions, write them to me. I would be very happy to explain even in more details how to do this thing. And I could do also a short video about the exact points and ways to measure pulse wave velocity. So a question arises here. Which is the right distance that we should measure? The time, it is clear, we don't have here any controversies, but about the distance, the things are not so clear. Because we could measure, of course, the whole distance from the right carotid to the right femoral artery, but we know that the pulse wave did not travel that way, starting from the carotid and going straight down to the femoral artery. In fact, it starts from the heart, gets through the ascending aorta arcus, and then divides one part to the carotid artery and the other to the femoral artery. We could get some different calculations from different parts of this whole distance, but what is accepted for now, for the purpose of standardization of this measurement, is to take the whole distance and then take 80% of it. So the whole distance is multiplied by a factor of 0.8. Another useful things for the measurement of carotid femoral pulse wave velocity are the following. You should make two measurements and take the mean value. If these two measurements differ with more than 0.5 meters per second, then you should take a third measurement and take the median. The distance and the measurements are made on the right carotid and right femoral arteries. The carotid femoral distance is measured as a straight line, and there are some contraindications for these measurements, and they are mainly arrhythmia, unstable clinical conditions, significant carotid stenosis. If you don't have a Doppler on the arteries, just put a stethoscope on it, and if you see some significant noise, then don't perform this measurement. And if we have, of course, sinus caroticus syndrome, because these patients tend to develop syncope when this region of their neck is manipulated. And towards the end of my presentation, I would like to show you this scheme. This is from the Arterial Hypertension Guideline Management from 2018. Here are different methods of assessing target organ damage and the way they react to some changes, their sensitivity to changes, their reproducibility by different operators, the time that is needed for their change, and the prognostic value of this change. And I would like to compare LV hypertrophy by Takehome, which has a moderate sensitivity to changes. It has also a moderate reproducibility and operator independence. The time to change is moderately long, around and over 6 months, and it has, of course, some prognostic value for the future of these patients. Let us now see the pulse wave velocity. It has a very high sensitivity to changes. This means that when you do something to correct the blood pressure of these patients, you can expect to have a very high sensitivity for these changes, measuring pulse wave velocity. However, for now, the reproducibility between different operators is not very good, and this is partly because up till now there was not enough standardization of this technique. However, the time to changes is very fast. Week to months is needed after you start a certain intervention. If you measure pulse wave velocity at baseline and then you measure it several weeks or a month later, you could see if this intervention has some positive effects on the blood pressure and on the arterial properties, elastic properties, and stiffness indices of the arteries. Up till now, we don't have more data about the prognostic value of the changes. So, my dear friends, now I am reaching the take-home messages, and some of them are that stiffening of the arteries is a feature of a physiological vascular aging that is accelerated in many kinds of pathological conditions with increased cardiovascular risk, such as diabetes, hypertension, dyslipidemia, and so on and so on. By itself, arterial stiffness is a strong risk factor for a broad spectrum of cardiovascular diseases, and we have seen the bidirectional link between arterial stiffness and hypertension, and also it could lead to heart failure, myocardial infarction, and stroke. A very important thing from this presentation is that arterial stiffness could be very easily measured without the need of any sophisticated equipment. It appears to precede the onset of overt organ damage, and considering all of these, the increased arterial stiffness may represent a critical causal link between the cardiovascular risk and the eventual disease, and therefore could qualify as a universal maybe target for some therapeutic interventions. This was all that I intended for now to tell you about arterial stiffness. If you like this video, if you think it is useful, please don't forget to give it a thumbs up. Also, don't forget to subscribe to my YouTube channel and click on that ring bell button so that you get notified whenever I'm posting a new video. Thank you and see you in my next video.